All right. Any specific questions about the psych medications before we get started on the psych packet? All right. So benzodiazepines, what do they end in?
Ham, lamb.
Pam and lamb. Good job. Yep. And is the drug of choice for what type of withdrawal?
Let me go
Alcohol.
take a shower.
Good job. Yep. So it is habit forming. So we typically want to use it PRN. Okay. It does cause that CNS depression. So we would want to avoid other CNS depressants such as alcohol. And what's our priority vital sign to monitor during this time?
Blood pressure.
Blood pressure is important, but I'm going to go with respiratory rate. Kind of like our pain meds, it's going to drop everything. Okay. So we know we just talked about we want to take it as needed. We don't want to take it all the time. But if somebody takes this regularly, what is your priority?
Is it don't stop abruptly?
So you're not going to stop it abruptly. So if I come in, you're my nurse, and I tell you I take diazepam every night before I go to bed, you're going to want to get me an order for a benzo so I don't go into withdrawal. And what is our antidote? Yep. Okay, great. All right. And then what about our non-benzos? So how do we take our buspirone? We take it regularly, and what do we need to avoid? Yep.
Is it grapefruit juice? Oh, yeah, grapefruit
Yep. Yep. Grapefruit juice. And how long does it take to see results from this medication?
juice. 2 to 4 weeks, I think.
Yep. Yep. So this is one, it's not going to work immediately like a benzo would. So we need to tell the patient, hey, it's not going to work immediately. You need to stick with it and take it, and you're going to see, it's going to take about 2 to 4 weeks to see effects, or they'll stop taking it. Okay. Okay. So for our depressive disorders, we have our SSRIs, fluoxetine, citalopram, sertraline. What neuroreceptor do these medications increase? Serotonin. And when do we take them?
In the daytime,
Yep. And how long before it starts working? Under 3 weeks. Good job. All right. All right, Frenchie. um, what kind of complications do we get? Does our weight go up or down?
is it down?
Up.
Weight gain.
Okay.
So we can have weight gain. Yep. And then sexual dysfunction. So we need to let them know that this could happen. And if it does, we give them a medication to help fix the problem because we don't want them to stop taking their antidepressants just because of the sexual dysfunction. Okay. So we
Most psych
are,
meds, Miss Greenbaum, don't most psych meds
yep,
cause that?
yep. Which is why we'll just put them on something to kind of help counterbalance it. It can also cause teeth grinding, so they may need to wear a night guard with SSRIs. If that doesn't work, then we may have to switch them to a different form of antidepressant if their teeth are kind of grinding down. So we're increasing the serotonin, so we have risk for serotonin syndrome. Then, okay. So how soon does serotonin syndrome start after taking the medication?
72 hours.
Yep, 2 to 72 hours. They need to be looking for these signs and symptoms. So it's going to start with some confusion, disorientation, auditory or visual hallucinations, some delirium, seizures, tachycardia, nausea, vomiting, diarrhea. If left untreated, they can become apneic and then it would lead to death. If left untreated, it is very lethal. So a big thing, what we've talked about this before, what herbal remedy would increase your risk for serotonin syndrome?
St. John's wort.
Yep. And then they're now having an increased risk of suicide for the first few weeks. Why?
Because they have the energy to complete a suicidal offense now.
Yep. Yep. Energy. So this medication, it's going to give us that boost of energy right away, but it's going to take that 1 to 3 weeks to start working on the depression. So while they get that boost of energy, but their depression hasn't quite been taken care of yet, they have that boost of energy to actually complete a suicide attempt. Okay. All right. So now we have our SNRIs. So this one's going to work on 2 neuroreceptors. Which ones are they?
Serotonin.
And norepinephrine.
Yeah.
And norepi. All right. So of course, if we're increasing the serotonin, we're still at risk for
Serotonin syndrome.
serotonin syndrome. Like we said earlier, almost all of them cause sexual dysfunction. And this one can cause hypertension.
I
Okay.
have a question. When you say
Uh-huh.
sexual dysfunction, do you mean in both women and men, like they don't have the desire, or do you mean a
Yes.
man can't get? Okay.
So it can happen in men and women. It decreased libido. It can cause impotence in men and the inability to have an orgasm in women. All right. So our trazodone, so then we have our atypicals. These ones are kind of oddballs, and these are basically opposites of each other. So the bupropion we talk about a little more when we talk about smoking cessation. And the trazodone does kind of the opposite. So our trazodone, what's one of our biggest complications of trazodone?
CNS depression.
Yep, sedation. So what is a other use for this medication aside from depression because of its sedating effects?
Anxiety, insomnia.
Insomnia. And what can we not take with it?
Grapefruit juice.
Yep.
Is it grapefruit or grape?
Grapefruit.
Okay.
So with our bupropion, we have our anti-chlorogenic effects. And then increased what?
Heart rate.
Yep.
And hypertension.
Yep. Increased heart rate. And blood pressure. Because of the increase in everything in the CNS excitation, we worry about seizures.
So that means that the CNS, like, that'll increase.
Yep. Opposite of CNS depression. Yep. All right. So then we have our tricyclic antidepressants, which is our amitriptyline, our nortriptyline. These two increase what neuroreceptors? Serotonin and
Norepinephrine.
norepi. Yep. And how long does it take for the onset of the effects to start working?
2 weeks.
Yep. 10 to 14 days. And then how long for full effects?
4 to 8.
48 weeks. And stuff. All right. And what do we worry about with this?
Orthostatic.
Orthostatic hypotension, anti-chlorogenic effects, sedation. What do we see? What kind of toxicity do we see?
Cardiac.
Cardiac. So what do we need to get a baseline before we start them on this meds?
The EKG, right?
Yep, EKG. So baseline EKG, and then every follow-up we'll get another one. When I worked at a neuro clinic for a while, and we treated saw kids with migraines. Amitriptyline, a off-label use for TCAs is pain, including headache, fibromyalgia pain, things like that. But before we could start them on it, we would have to get a baseline ECG before we could start them on it. And it does lower your seizure threshold, so we don't want to put you on this if you have a high risk for seizures. And then it can cause diaphoresis or sweating. All right. Any questions on these? Okay. All right. Everyone's favorite, MAOIs. Okay. So phenlazine is the big one that we see for psych. We see an MAOB for Parkinson's that I'll talk about in a little bit, but it's kind of the same deal with that. If these are MAO inhibitors, what do they block? Or I just gave it away. So they block those enzymes, MAO enzymes. Okay. And in turn, it's going to increase norepi, dopamine, serotonin, and tyramine. Tyramine is going to be your big one for this one. And how long till onset?
2 to 4 weeks.
All right. So this can give us CNS stimulation orthostatic hypotension, but could also give us what if mixed with the wrong things?
Hypertensive.
Hypertensive crisis and rash. Okay. So this one is pretty much contraindicated in everything under the sun. The only thing is you can have grapefruit juice with this. Okay. This is why it's not used as often. It's kind of a last line resort. So, of course, it is tetragenic, so don't use it in pregnancy. Any of these medications right here that are for antidepressants, that's going to increase our serotonin. So we would be at risk for what with mixing them?
Is that the serotonin syndrome?
Serotonin syndrome, yep. It messes with our ability to process a lot of seizure medications. Cardiac disease, of course, it's hard on the heart because of the hypertensive crisis and the orthostatic hypotension. You can lose control of your diabetes. You don't want to take it with seizure disorders. And then you have issues with ephedrine or pseudoephedrine. Remember, that's our decongestants, in our amphetamines, which is our CNS stimulants that we'll talk about here in a minute. And also medications like diphenhydramine, our Benadryls, our antihistamines. Those are going to be the ones that are going, and tyramine are going to be the ones that cause the increased blood pressure for the hypertensive crisis. Okay. So what kind of foods have tyramine in it?
Aged
Pepperoni.
Yep. Aged cheese.
red wine. Oh, that's on there already.
Yeah, red wine. Pepperoni. And one more kind of, I don't know if it's a fruit or a vegetable. Yeah. Avocados. So let's talk about some things. What is aged cheese?
Is it like the hard cheese? Like
Hard cheeses that you would actually have to cut into like with a knife. This is gonna be like your cheddar, your blue. You can have, but not your soft cheeses like your ricotta or your cottage cheese. That's where ATI likes to trick you. So, can you have a cheese pizza?
Mm,
No. Got mozzarella, got
no.
cheddar. No. Can you have a avocado toast?
Yeah.
No, because it's still avocado.
Nope.
Oh no,
Yep.
no, because caramel.
Can you have a banana smoothie?
No.
No. Can you have cottage cheese and crackers?
Yes.
Yeah.
Yes.
Yes.
Yes. Cottage cheese is safe. Can you have grapefruit juice?
No.
Yes.
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 Yes. One of the few things you can actually have with this medication. All right. All right. So for our bipolar disorder, we talk about lithium. Lithium has a very, very, very narrow therapeutic range. So what is our safe lithium level? Zero point 0.6 to 1.2. Okay. So when do we, at what level do we start seeing our early manifestations, kind of our confusion, our discoordination, we get a little cords tremor, things like that? Yeah. Okay, so 1.5 to 2. Okay. And then we get our advanced at 2 to 2.5, where we're going to get tinnitus, involuntary movements, hypotension, coma, death. We can get polyuria to try to push some of this out. And if we don't catch it and it gets above 2.5, we're going to have oliguria, seizure, coma, death, and they'll need hemodialysis to get all of this out of their system. So what do you think we're going to need frequent of while someone's on this medication? Lab work. Aside from the lithium level itself, what will we be monitoring?
Eyes and nose.
Eyes and nose, BUN creatinine. What else?
Sodium.
Sodium. So we need, you can get hyponatremia. So we're going to monitor our sodium, monitor our water intake, make sure we're not getting dehydrated, all of that good stuff. Okay. So biggest thing is when you're in this advanced stage between the 2 and the 2.5, you're going to have lots of urination, some tinnitus, and involuntary movements. Once you move out of that stage, you've peed everything out that you can pee, so you get that oliguria. You can that dehydration and electrolyte imbalance will cause seizures, and you'll slip into a coma and die. All right, these first generation antipsychotics, I feel like there's just so much about them. So first and foremost, which of these two medications right here, which one is high and which one is low?
The first one is low.
Mm-hmm.
The second one is high.
Yep. And then what does low and high potency kind of refer to with the type of side effects? What is low potency typically going to cause? Less side effects, less problems. Highs more likely to cause more issues. Is that not to say that a low potency medication can't cause EPSs? Could a low potency antipsychotic cause acute dystonia?
Yes.
Yes.
Yes, it's just less likely. Mm-hmm. All right. So our goal with these is we're going to block the dopamine, acetylcholine, histamine, and norepi. So we have a big one that comes along with our first generation antipsychotics are these EPSs, the extrapyramidal side effects. Oh, stop it. Which EPS is life-threatening? Yep. Acute dystonia. Why is it life-threatening?
Because it causes spasms.
Of what specifically?
Larynx.
Yep.
The
That
face.
larynx and the pharynx where you're breathing from. Okay. Which type of EPS is going to cause that bradykinesia, rigidity, shuffling gait, drooling, or tremors. Yep. Parkinsonism. This is also called pseudo Parkinsonism, because you have pretty much the exact same signs and symptoms as you get with Parkinson's disease, but you actually don't have Parkinson's disease. It's just mimicking it. And which one is going to be the inability to sit still? They're going to be pacing and agitated. Akathisia. And then which one involves the lip smacking and other involuntary movements of the face? Tardive dyskinesia. All right. And what is our other life-threatening complication from first-gen antipsychotics?
Neuroleptic malignant syndrome.
Neuroleptic malignant syndrome, which is a lot like what disorder that you see a lot that we all probably talked about in med surge from surgery, from anesthesia.
Hypothermia malignancy or hypo.
Yep, malignant hyperthermia,
Yeah,
where
that too.
you get that sudden high-grade fever, blood pressure goes up and down, muscles become rigid, your heart starts beating out of whack, you start getting sweaty, you lose your level of consciousness. Just like with malignant hyperthermia, same thing. You take away the source that's causing it, in this case, an antipsychotic, cooling blankets, antipyretics, diazepam to stop a seizure, and dantrolene, which dantrolene we talk about in the neuro section, but that's also your treatment for malignant hyperthermia. These guys are going to go to the ICU, and then they have to wait 2 weeks before they can get put on another antipsychotic. Okay. With this, it's when we start talking about the difference between first and second generation antipsychotics, it's important to know the difference between positive and negative manifestations. What are, because these obviously don't mean good or bad, what are positive manifestations of psychosis?
Like auditory visual hallucinations, delusion.
Yep. So I usually write this with a plus sign because it means things are added that shouldn't be there. This could be things like hallucinations,
So like
paranoia.
abnormal stuff, right?
Yeah, well, all of it's abnormal, but
Oh,
this is things that's there that should not be there.
okay.
Whereas a negative negative manifestations are normal attributes are gone. This is going to be like our apathy, your flat affect, your not not having pleasure in the things that you do. Things like that. So things that should be there but are gone. Okay. What type do first generations take care of?
Is it generalized anxiety or
So positive or negative manifestations? Which the positive,
Positive.
positive.
got you? Okay.
First generations are going to take care of your positive manifestations. Okay. And then when we go to second and third generations, like our clozapine, our risperidone, and our aripiprazole, we're going to have less side effects. We're not going to have, neuroleptic malignant syndrome. We're not going to have acute dystonia. And we're going to be treating the positive and negative associations. So we're going to treat both.
Can you go back to slide 23 real quick, please?
Mm-hmm.
Okay.
Got it? Cool. So our side effects that we do get, we have to monitor our blood sugar so we can either get a new onset of diabetes. Rianne?
I'm sorry, I'm just a little confused on the potency thing when you were talking
Uh-huh.
about like low potency versus high potency.
Mm-hmm. So a low potency is first generation is going to be less likely to cause side effects. Not that they can't, they're just less likely to. So you have more of a chance of getting neuroleptic malignant syndrome with haloperidol than you do chlorpromazine. Does that make sense?
Okay.
We're going to get some weight gain with this. Antichlorogenic, orthostatic hypotension, agitation, dizziness, sedation, or sleep disruptions. The big thing to remember about our second and third generations is that they are contraindicated in clients who have dementia. Any questions about those? All right. So now we have our CNS stimulants. What are these medications used for?
ADHD.
What else?
Obesity, narcolepsy.
Yeah. Okay. So because it stimulates you, it keeps you going, wakes you up. What time should our last dose be?
4.
100.
4 o'clock.
Mm-hmm.
To try to prevent some of the anorexia and weight loss, when do we give it?
Either before or after meals.
Right at meals.
Right. Yep. Right at meals, either before or after. We want to monitor for shortness of breath, chest pain because of that stimulation that it gives you. And it can because it is causing that excitation in the brain, that CNS stimulation. We want to monitor for any type of hallucinations and paranoia because it can trigger that. It also, of course, MAOIs we already talked about. It'll cause that hypertensive crisis. Caffeine, we don't want to give any other stimulants. phenytoin, phenobarbital, and warfarin, it messes with your absorption. And cold and decongestant meds is going to increase your risk of hypertension. Any questions on stimulants? So the first thing we talked about was alcohol withdrawal. When is that onset?
4 to 12 hours.
4 to 12 hours after the last drink. And how long can it last?
5 to 7 days.
5 to 7 days. Tremors, restlessness, irritability, increased heart rate, blood pressure, respiratory rate, temperature, and can cause tonic-clonic seizures. When you have someone who comes in who regularly drinks alcohol, your priority is knowing when their last alcoholic drink was consumed. That way we can try to give what medication to prevent the withdrawal.
Benzo?
Benzo. Good job. We can get alcohol withdrawal delirium, which is a medical emergency. When can that onset?
2 to 3 hours. 2 to 3 days.
2 to 3 days. And that is why it's very important that we're monitoring for the withdrawal to try to prevent the DTs. So once we've got them withdrawn and they're done, and they actually want to stop drinking, you already told me this, your priority is a benzo. We have some medications that can help with the abstinence. Okay. So we have our disulfiram, which will make you sick if you what?
Drink alcohol.
Yep, drink alcohol. So it's aversion therapy. It gives you a very unpleasant sensation if you drink alcohol with this. So before we give somebody this, our other priority is knowing our last alcoholic drink. Because if they cannot abstain from this, from alcohol, we do not want to give it to them, because continued use of alcohol while on disulfiram, it can actually kill them. Okay. And another big issue that we have is hidden what?
Alcohol.
Yep. And then alcohol. So mouthwashes, they need to get alcohol-free mouthwashes. You have to be very careful with things like hot sauces, hand sanitizers. You go pump hand sanitizer in your hand and then touch your face and lick your lip. That's all she wrote. Cold cough syrups can have alcohol in it, so you have to be very careful. It's not just like how our body doesn't care if we take prednisone for asthma or for rheumatoid arthritis. It's going to cause the same symptoms. Our body doesn't care what the source of alcohol is. It doesn't care the difference between mouthwash and gin and tonic. It just knows there's alcohol and it's going to react. Okay. And then we have naltrexone. What does naltrexone do?
Decreases the cravings and like pleasurable effects.
Mm-hmm. Yep, of alcohol and opioids. So this naltrexone can be used for opioid withdrawal as well. And then I've seen ATI talk about this one a lot, the camprosate. So this one's going to decrease our effects of not having the alcohol, which could be our sweating, anxiety, restlessness. We should tell them it can cause what?
Diarrhea.
Mm-hmm. Diarrhea. They're going to take it 3 times a day. So it's pretty strict management. We want to take it with food. And we need to stay very well hydrated. And we do not want to use this while pregnant. Any questions on alcohol abstinence? Okay. All right. So what is our goal with methadone?
Prevent withdrawal symptoms.
Yep. But the dependence to our methadone replaces a dependence to other opioids or our illegal opioids. Okay. What does clonidine do for us?
Mask the effects of withdrawal.
Yep. What does it do not do for us?
Reduce cravings.
Yep. Does not reduce cravings. So we're going to have to put them on something else with the clonidine. Of course, we talked about clonidine during our blood pressure chapter. It can lower your blood pressure. So all of those same rules apply. Buprenorphine is Suboxone. It's considered safer than methadone. It can be given at home as aside from methadone, which has to be given in a clinic. All right. So then we have our medication for nicotine abstinence. What does our bupropion prevent?
Withdrawal.
Yep. Withdrawal symptoms, which are going to be that insomnia, restlessness, nervousness, and irritability. We do not want to have any kind of caffeine or other stimulants with this medication. Okay. Varenicline is our Chantix, and that's going to stimulate the same pleasure receptors that you get from smoking. This comes in a very strict titration category that has to be followed carefully. You can get unpredictable behavior, mood swings, and suicidal ideation. So it is actually like prohibited for people like bus drivers, pilots, things like that. And then we have nicotine replacement, which is going to replace nicotine normally received from cigarettes or chewing tobacco. So this is going to be like your gum, your patches, your inhalers, your lozenges, things like that. Okay. Any questions in that section before we go on to neuro? Okay. All right. So our first medication that I want to talk about is our donepezil. Jesus, I can't say that one. This can cause a cholerogenic crisis, which is the opposite of what?
Anticholinergic.
Yep. Opposite of antichlorogenics. So with a antichlorogenic can't see, can't pee, can't see, can't spit. With a cholerogenic crisis, you can get paralysis of the respiratory muscles, and you can get excessive salivation, lacrimation, which is excessive tear production, urinary incontinence, diarrhea, GI cramps, vomiting, things like that. What is our treatment for a cholerogenic crisis?
Atropine.
Atropine. Good job.
Tore that all up.
Hey, if you can figure it out on multiple choice, you're fine. All right. Right. So then we have our Parkinson's medication. What is our goal for this? What are we increasing? We want to increase dopamine and decrease acetylcholine. Okay. And it can cause our carbidopa levodopa can cause a on-off phenomenon. So what is that? What is an on-off phenomenon?
Can occur anytime, I guess.
It can occur anytime. And how long can it last?
Minutes to hours.
Minutes to hours. Yep. And so it's basically it's a wearing off effect that can occur at the end of a dosing interval. So it kind of means that you need more medication. Where it can occur spontaneously. It's basically like the medication just stops working for a few minutes to a few hours, and then it picks up and starts working again without any issue. Okay. How long are the benefits of levodopa carbidopa good for?
In a year, 5.
5
Yep,
years.
5 years. And what kind of diet is needed for this medication?
Small servings of protein.
Yep, small servings of protein. So we don't want to tell someone not to have protein, but we want to use small servings, and the servings should not be given during medication administration.
Wait, go back. 1 second. Okay, thanks.
Okay, so with our anti-epileptics, we have traditional versus newer. With our phenytoin, we can get CNS effects, gingival, what?
Hyperplasia.
Yep, which means your gums are going to bleed a lot easier. You have to have good oral care, skin rash, heart effects, endocrine issues, things like that. Carbazepine, we have CNS effects. So typically we're going to go up very slowly, and the largest dose is going to be at bedtime. We can have blood dyscrasis. So this is just going to be our hematological effects. The biggest thing for that is messes with your blood. Hematological. Hypoosmolarity and skin issues. Okay. Valproic acid can affect your ammonia, so we want to monitor your ammonia level. It can cause GI upset, and it can cause pancreatitis and hepatotoxicity. And it can also cause what?
Thrombocytopenia.
Good job. And what does that mean?
Bleeding.
You're at risk for what? Yep, bleeding. You're at risk for bleeding, so you're not going to clot off very well. So if you mix valproic acid, you have a high risk of bleeding, and then if you mix it with something else that causes bleeding, you have an even higher risk of bleeding.
I got a question.
And then, yeah.
So these medications prevent like
seizures.
Okay.
Yes, they can't. Some of them can also be used for bipolar disorder, but again, the signs and symptoms are still the same.
Okay.
Yep. With lamotrigine, we're worried about Stevens-Johnson syndrome. Remember, that's that deadly rash. So for these people, a rash, you want to report immediately. Okay. And topiramate can cause
You said with
metabolic.
lamotrigine, Ms. Greenbaum?
Yes. Lamotrigine can cause Stevens-Johnson, and topiramate can cause metabolic acidosis. A big thing with all of these medications is do not stop abruptly. What could happen if you stopped an anti-epileptic medication abruptly, especially if you're using it for seizures?
Your seizures can come back.
So yes, your seizures can come back, and then even worse, it can lead to status epilepticus, which is a seizure that does not stop by our normal means. So normally when someone has a seizure, we can give them diazepam, and the seizure will stop. This is a medication. This is a seizure that we cannot stop by traditional methods. So it's a prolonged seizure, which can cause brain death or overall just death.
So how do you, I mean, if they was to have this like in a hospital or something, like, is there like
Status epilepticus?
Yeah, is it like an antidote or something, or like
The
IV?
biggest, I mean, we just have to keep pushing benzos and hope the seizure stops, and push their seizure meds and hope their seizure stops.
Okay.
I had one girl, she was she was normal, walkie-talkie. She was at home, she was out with her friends. She chose not to take her medication at a sleepover. She had a seizure that was 27 minutes, and now she's wheelchair bound and almost completely brain dead. In the hospital, they worked on her for a long time, but it took her 27 minutes for that seizure to stop. So she lost a lot of brain during that time. So that's why we really critically tell our patients not to stop this medication. It has to be tapered down slowly under the eyes of a physician. All right. So now we have our neuromuscular blocking agents. This can be our pancremonium or our succinylcholine. So what is our complications with this one? We talked about it earlier.
Malignant hypothermia.
Yep, malignant hyperthermia. So muscle rigidity, temperature increase, stop med, give oxygen, cooling blankets, ice, normal saline, ice to the groin, and we give dantrolene, same treatment. We need to have life support or resuscitation equipment available because this is going to paralyze the patient's muscles. So that's going to stop their ability to what?
Say the question again.
So why do we need to have life support available? If it's going to stop their ability to move their own muscles, what are they going to stop doing?
What the
Breathing.
respiration, breathing?
Breathing. Yep. They're not going to be able to breathe on their own. So a lot of times we give this to paralyze the respiratory system so we can place an intubation tube. Okay.
Miss Greenbaum.
Yeah.
Yes, with that, would the heart also stop pumping or stop contracting?
It could. Your respiratory muscles are going to go first because that's something that you're kind of controlling. Your heart will keep going. But yes, it could eventually stop if you're not getting oxygen.
Okay.
Which is why it's important to use the life support, intubate them, hook them up to the machines.
Got it.
Yep. Muscle relaxants or antispasmodics. So with our centrally acting, we talked about diazepam. We already talked about that. I beat that horse to death, so we didn't go back over it. And then we have baclofen. The biggest thing I need you to know about dantrolene is that it's the treatment for neuroleptic malignant syndrome and malignant hyperthermia. With our baclofen, what are some of our complications? So nausea, constipation, urinary retention. How do we know baclofen's working?
They won't have as many muscle spasms.
No muscle spasms. They may be able to move their arms more freely depending on how severe their muscle condition is. Yep. All right. So these two are opposites. So we have our Bethanical. What is that used for?
Non-obstructive urinary retention.
Yep. So what do you think it's going to make us do?
Urinate.
Urinate. So it's going to cause chlorogenic effects. So increased gastric acid, cramps, diarrhea, sweating, tearing, urinary urgency. It's going to drop the heart and the blood pressure, and it can cause bronchoconstriction. But it is going to make us urinate. So if it's going to make us urinate, what is oxybutynin going to do?
Stop the urination. It's for
Stop the
overactive bladder.
urination. Yep. So it's going to treat overactive bladder. And it's going to cause what kind of effects?
Anticholinergic.
Yep. Can't pee, can't see, can't shit, can't spit. Along with hallucinations, confusion, insomnia, nervousness, prolonged QT intervals, and tachycardia. So again, they're the opposite of each other. So just remember one, you'll know the other. All right, we are almost done. Solid work, guys. All right, zolpidem, this is our Ambien. What is it used for?
Short-term for insomnia.
Yep, short-term use for insomnia. How much sleep do you need to get after taking this medication?
8 hours.
8 hours. And then, so of course, getting that 8 hours of sleep will help prevent our complications such as daytime sleepiness, lightheadedness, headaches, and what?
Sleepwalking.
Sleepwalking or other sleep activities. I've all heard the horror stories about Ambien. And then take on what?
Empty stomach.
Empty stomach.
Empty stomach. Yep. Of course, if it's sedating, what do we want to avoid?
Driving or operating heavy machinery.
Yep. Avoid other CNS depressants like benzos, alcohol, cough syrups, things like that, and then avoid driving, operating machinery until you know how the medication affects you. Right? And now we got our Ramelton, which is used for chronic insomnia for when what is difficult?
Sleeping.
Falling asleep.
Falling asleep. This medicine does nothing to help us stay asleep. Okay. And just like with the other medication, you want to avoid what? CNS what?
Depressants.
Depressants. Job.
I'm sorry, I got a question.
Yeah.
So this medication and then the other one, what's the difference between the two? Because you said this one is
So this one can be used for chronic insomnia, so it can be used for long term.
so it'll help you to fall asleep, basically,
Yes.
but it won't.
Yes.
So when you fall asleep, I mean, are you just sleep for a few hours and you wake up, or I
So you
mean,
wouldn't use this if you're someone who falls asleep and wakes up constantly throughout the night, this medication will not help you.
okay,
So you would take this. So once you're asleep, you're good. But falling asleep, winding down is difficult for you.
okay,
This happens a lot with people. I used to take this medication when I worked night shift because it was hard for my body to adjust to falling asleep during the day.
okay. And then the other one is just for insomnia.
Insomnia, and it's for short-term use. I got put on this medication for 3 days when I switched from night shift to day shift. But
Okay,
usually they won't give it to you for more than like 2 weeks.
okay.
Yep. All right. And then we have our IV anesthetics. Our big ones are ketamine and propofol. So this is going to be used in conjunction to help put you asleep for a surgery. So a lot of times you'll get propofol to knock you out for the surgery, and then you may get something like procrium, pancreonium bromide, which is that neuromuscular blocking agent that we talked about earlier, to pause the respiratory system so we can actually intubate you. But propofol is what actually knocks you out, puts you to sleep. So, of course, with this, we want resuscitation equipment ready. And who can we not give what with? Do not give.
Is it the? I don't know. Never mind.
It's okay. Do not give ketamine to clients with a history of mental illness, especially psychosis, because ketamine does have a nasty side effect of auditorial and visual hallucinations. So if you already have a history of that, it's going to make it worse. All right. And that is it. Any other questions?
This is a lot, and I'm annoyed.
Huh?
This is a lot, and I'm annoyed.
Why are you annoyed?
This is a lot. This is a lot. This is a lot of
It's all good.
information.
It's all good. But this is it. This is it. This is all of the new information that I have for you.
What we doing tomorrow?
Tomorrow, I am going to be giving you kind of the nitty-gritty of the neuropsych stuff that you'll need, that I think you'll need for the proctor. You'll be doing practice B for the proctor, and I have a mini review of past content for the proctor for week 14.
Okay.
And then week 14, we'll be going a little more in depth on this stuff.
On what stuff?
The neuropsych stuff for the final.
There's more?
No, this is it. I'm just going to give you like what I would normally give you in class. I'm not doing tomorrow because of the proctor.
Oh, okay. Whew.
Yeah, no. This is it. This is it. I know it's a lot, but it's it.